Hello, everyone, and welcome to this latest edition of the Systems for Action Research in Progress webinar series. My name is Anna Hoover, and I am the co-director of the Systems for Action National Coordinating Center here at the University of Kentucky. As many of, if not most of you know, Systems for Action is a national program of the Robert Wood Johnson Foundation that studies how we can better align the systems that support a culture of health, including the financing and delivery systems for public health, healthcare, and social and community services and supports. Today we are very excited to share some research funded through the Systems for Action program that is going on in Philadelphia. Our agenda, we will be hearing shortly from 3 speakers. 2 will describe this exciting work with the Building Wealth and Health Network in Philadelphia, and I would like to encourage you as you hear these presentations to please make use of your chat box on your screen. As questions arise, please type those questions in there. We'll have time at the end of the call today to go through as many of those as we can get through and have some robust discussion. But today's presentation is going to be led first by Dr. Mariana Chilton, who is a professor at the Dornsife School of Public Health at Drexel University. She is the director of the Center for Hunger-Free Communities and co-principal investigator of Children's Health Watch, a national research network that investigates the impact of public assistance programs on the health and well-being of young children and their caregivers. Dr. Chilton founded Witnesses to Hunger, a participatory action study to increase women's participation in the national dialogue on hunger and poverty. She is principal investigator of the Building Wealth and Health Network, which is a trauma-informed peer support and asset building program designed to incentivize entrepreneurship and self-sufficiency among families with young children participating in the Temporary Assistance for Needy Families program. Dr. Chilton has testified before the U.S. Senate and U.S. House of Representatives on the importance of child nutrition programs and other anti-poverty policies. She also has served as an advisor to Sesame Street and to the Institute of Medicine, which is an interesting set of advisees. She will be accompanied today by Dr. Sandra Bloom, who is a board-certified psychiatrist and an associate professor at the School of Public Health at Drexel. In addition, Dr. Bloom is president of Community Works, an organizational consulting firm committed to the development of nonviolent environments. Dr. Bloom currently serves as Distinguished Fellow of the Andrus Children's Center in Yonkers, New York. From 1980 to 2001, Dr. Bloom served as founder and executive director of the Sanctuary Programs, inpatient psychiatric programs for the treatment of trauma-related emotional disorders. In partnership with Andrus Children's Center, Dr. Bloom has established a training institute, the Sanctuary Leadership Development Institute, to train a wide variety of programs in the Sanctuary model. The Sanctuary model is being applied in residential and multi-service treatment programs for children, inpatient mental health programs, schools, domestic violence shelters, group homes, homeless shelters, juvenile justice programs, and communities across the United States and internationally. After we hear from Drs. Chilton and Bloom, we will have some commentary from Dr. James Ziliak. Dr. Ziliak is founding director of the Center for Poverty Research and founding executive director of the Kentucky Federal Statistical Research Data Center at the University of Kentucky, where he holds the Carol Martin Gatton Endowed Chair in Microeconomics in the Department of Economics. He is also a research fellow at the Institute for Fiscal Studies. Dr. Ziliak is co-investigator for the Systems for Action National Coordinating Center. His research interests are in the areas of labor and public economics, with a special emphasis on U.S. tax and transfer programs, poverty measurement and policy, food insecurity, and inequality. And again, we'll be hearing from Dr. Ziliak after the presentation. Please do remember to use that chat box as we go through, and with that, I'm going to hand the mic over to Dr. Chilton.
Thank you so much, Anna, and hello everyone. I'm Mariana Chilton, and I'm really delighted to be here to talk to you about the Building Wealth and Health Network and how we're working through the Systems for Action mechanism to find ways to better integrate behavioral health with TANF, or Temporary Assistance for Needy Families, to build a culture of health in education and training programs. So I'll tell you what I'm going to talk about, and then we'll launch right in. I just wanted to review the Systems for Action goals for our particular endeavor through Systems for Action. And I'll just review very quickly temporary assistance for needy families and some of the challenges that families have to reach economic success. I want to do a review also about the experiences of trauma and what is trauma-informed practice to make sure that we're all on the same page. And then we'll launch right into describing the program, the Building Wealth and Health Network, and we'll present to you preliminary outcomes. So I want to give you a little bit of a warning that these are preliminary outcomes. We are collecting data as we speak continuously, and so we're still working on solidifying our outcomes, but we do expect to be publishing on that come spring and summer. I'll be talking about next steps as well. So first I wanted to just introduce you to who our teams are. I'm working with Dr. Sandra Bloom, who's our co-PI. We also have Jerome Dugan and Layla Boucheri from the College of Nursing and Health Professions. And our project director is Falguni Patel. And we have many others that are working on this program. And I think it's important to recognize their really fundamental work that they're doing on this program. So for the Systems for Action program, we have 3 goals. We first want to assess the effects of our trauma-informed peer support that's built into the education and training of TANF, this programming of TANF, to see how they have an impact on the health and economic security of families with young children. All of the people that we work with have young children under the age of 6. Secondly, we're very eager to identify the cost savings to both TANF and to Medicaid by this program and be able to make a very strong case for linking the 2 systems. Thirdly, we're very people-oriented and people-centric, and it's really important for us to include the members of the network as stakeholders along with experts in the fields of public health and asset building and behavioral health to help promote a culture of health within anti-poverty programming. So we have a public dissemination effort that's just getting started. So just to review, TANF, it stands for Temporary Assistance for Needy Families. In order to be eligible for TANF, a person needs to have an income at 50% of the federal poverty line and below. Across the country, nationally, TANF does not reach all of those who are eligible. Only about 25 to 30% are participating in this program. In order to receive benefits from cash welfare or TANF, an individual has to participate in something called work participation, and it's a requirement. And overall, over the years, the past 20 years of TANF, there's been a lot of recognition that the education and training programs are not really helping people to reach their full potential. And what happens is people go into, tend to be encouraged to go into low-wage jobs where they, after a few months or 6 months, lose that job and come back to TANF, and that's called churning. There's also a strong recognition that many people who are participating in TANF have major barriers to work. 33% report work-limiting health conditions, 43% report having a disability. There are very high rates of intimate partner violence among those who are participating in TANF, and also a lot of involvement with the criminal justice system. All of these are major barriers to succeeding in the workforce, and they really they must be addressed in order for people to have some success. So I just wanted to give you a little bit of an emblematic story from someone that we know very well, and that's Joanna Cruz. She's a member in our other program called Witnesses to Hunger. The photograph on the left is Joanna with a picture of stickers on the wall, and then also on her chest it says, "I'm an ER visitor." When I met her, she was living in a home that had no running water. She was taking care of a 6-year-old and a 2-year-old, and she was on cash welfare at the time. She said, "My kids are always sick. I'm always taking them to the emergency room because they're always getting flus and colds and rashes because we're living without running water." She took a photograph. That's a part of the program, is that they take photographs of their experiences of hunger and poverty and what they want to change in the systems. She said, "I really think that TANF needs to change. This is my job. I have to do community service in order to get my benefits." At the time, she was receiving just over $400 a month to work 20 hours a week at an organization where she needed to file endless file papers. She said, Mariana, look at this stack. It's very depressing. I'm deeply depressed, and this job is not helping me. And then finally, she took a picture of these 2 tokens, which she calls her sad little tokens. One of the important resources that TANF does provide for people as they try to encourage them to get into the workforce is assistance with paying for child care and paying for transportation in order to get to their jobs. These 2 tokens are bus tokens from Philadelphia, and she gets money from TANF in order to buy those tokens. She bought those tokens, but then she told me that she had to sell them because she didn't have enough money to feed her children. She had 3 days' work of work left, but only 2 tokens, which would get her through 1 day of work. Of course, if she doesn't show up to work, she loses her TANF benefits, and then things start all over again, and the deprivation gets worse. So I was thinking a lot about Joanna Cruz and many other people I've met who've experienced deep poverty, and they were all talking about the importance of doing systems change, how the systems really needed to invest in the potential of the moms and their young children, and they felt like their potential was not being invested in. So that's a little bit of a story in the background and helped us to create the Building Wealth and Health Network. Remember as well that she was experiencing a lot of depression, something that we recognize among many people who are poor, especially with young children, that young children who are growing up in deep poverty experience what we consider to be called toxic stress, which is an overwhelming and relentless type of stress that young children experience if they don't get adequate support from their families and their communities. That does include abuse and neglect, but it also includes homelessness and poverty and hunger. We consider those to be traumatic experiences that have lifelong consequences for children. And it also includes something called adverse childhood experiences, and I'll tell you about that in a minute. Also among adults, if they have experienced traumatic stress, it affects their ability to cope with external threats. And just like that trauma and toxic stress affects children's health and well-being and their brain structure, it certainly does affect adults. It affects their central nervous system. They become overwhelmed, and many other issues are associated with trauma. And again, I know I'm going quickly, but I think most of the people on this call have become familiar with the importance of trauma. But what's above here is that you see what's at the top, the tip of the iceberg is what we tend to see among people on TANF. They have a lot of behavioral challenges, physical illness, emotional dysregulation, and of course, financial instability and poor educational outcomes. That's what we see and we're trying to treat. But what's underneath that is exposure to trauma and violence, having to deal with a lot of loss, and the need to let go, chronic hyperarousal and inflammation, adverse childhood experiences, which I'll explain in a second, family and social dysfunction. But I'd also have to say that the roots of the trauma is not just in the family and in the community, but it is something that is passed on through the generations, and I think it's important to remember historical trauma across the generations in America, and we could get into the details if you would like during question and answer. But what's underneath a lot of the behavioral challenges of people on TANF is exposure to trauma and violence, something important to remember. Adverse childhood experiences are a series of experiences that can be measured for people asking about their childhoods before the age of 18. It has 3 categories. It includes abuse, neglect, and then also household instability, which is sort of an umbrella term for a number of other issues such as witnessing domestic violence, having someone in the family with a mental illness or substance abuse issues, or having a parent who is incarcerated. And it can be measured through a 10-question scale. I show you an example question of emotional abuse where the question reads like this: did a parent or other adult in the household often or very often swear at you, insult you, put you down, or humiliate you, or act in a way that made you afraid you might be physically hurt? As you can imagine, the people in the front lines asking these questions do bring up a lot of suffering and a lot of trauma among our participants, something important to remember that affects people across the lifespan. So there's a strong recognition in the social services community that we need to be recognizing the trauma, what's underneath of people's behavioral health problems, and also their lack of success in the labor market. And so we have been able to integrate a trauma-informed type of practice. And so I wanted to make sure everybody is familiar with what does trauma-informed mean. This comes from SAMHSA. We realize the widespread impact of trauma and paths to recovery. We recognize the signs and symptoms of trauma in our clients, our families, and our staff, and in our systems. We respond by fully integrating our knowledge about trauma into our policies, procedures, and everyday practice, and we actively resist any type of re-traumatization, either through our systems, our programs, and in our behaviors. So Sandy Bloom will talk a little bit more about the sanctuary model, but I've been quite inspired by her work, and she has a series of books about creating sanctuary and how social services can really improve if the culture of those social services could integrate a trauma-informed approach. Important to remember is this language of self. Self stands for sort of a four-domain type of way of interacting and understanding your social services. S stands for safety, E for emotions, dealing with emotional management. L stands for loss and letting go. F stands for future, and for the Building Wealth and Health Network, we've started to add freedom. It's a type of an organizing language for the type of programming and the type of organizational culture that's so important for really establishing and promoting a culture of health, especially among people who've experienced very deep poverty. So now we'll get into the Building Wealth and Health Network. Up on the right-hand side, you see our recruitment flyer. These are members of the Building Wealth and Health Network. This program has multiple components, but the most important one that we'll talk about today is that we offer group classes and peer support in a program that we call Financial Self-Empowerment, and it consists of 16 sessions. We also help each individual who comes to our program to open up a savings account where we can match their savings one-to-one up to $20 per month. We match their savings over the course of 12 months. Our curriculum has this language of self, as you see it here, and it brings people together. Again, these are all caregivers of young children, together in a group format where our facilitators or our coaches are working to establish a sense of connectedness and peer support among our members. So there you see our language of safety, emotions, loss, and future. All of the members of the network are introduced to the concepts of self, and then we weave those in to programming about how to manage your money, what does it mean to own a business, how do you negotiate good wages on the job, how can you earn more money and build your credit, and of course yield the benefits of that. Some of you may be surprised that we're focusing on helping people to own their own businesses, but one of the things that we've learned from our other programs is that people who are on cash welfare and who are working still can't make ends meet, and many times they participate in a sort of alternative economy. They are very entrepreneurial and will do hair and nails on the side and earn just a little bit of money on the side, and we're getting members of the Building Wealth and Health Network to think of themselves as entrepreneurs and job creators, and to legitimize what they consider to be side hustles. We're recommending that they see that as resilience, something that we can invest in and that can help them pull themselves out of poverty. This is just an example of some of the selected class topics. I won't spend too much time on it. This is being recorded, so if you want to learn about some of the components of our program, you can tune back in. But you can see, for instance, create your future, starting your own business. This is the last one. We want to help members gain the self-confidence needed to become an entrepreneur by teaching the basics of starting a business. But it also takes a lot of self-care, a lot of investment in self. We can talk more about that during question and answer as well. Our match savings program, as I said, is a one-to-one match up to $20 per month. We are partnering with American Heritage Credit Union union and the bankers come on site to help open accounts and collect deposits and helps to build trust with the bank. And of course, we do some visits to the bank so people can become comfortable with banking and investing in themselves. We do very comprehensive measurement with this program. We measure a lot of different characteristics at baseline and at 3-month intervals across 12 months. We measure basic characteristics, exposure to violence and adversity. We have a 2-generation understanding of our program. We know that if we're helping the caregiver, that we're likely helping the young child or the index child. So we measure health and development outcomes for both the mom and child. We have a few fathers as well in our program. We also measure economic security, which is a composite measure of food insecurity, housing insecurity, and energy insecurity. And finally, we measure financial well-being. So we are tracking the unofficial work and the self-employment that's going on. We are also measuring something called employment hope, self-efficacy, and also financial behaviors and knowledge. Of course, we're tracking the bank accounts as well to see how well people are saving and what kind of an impact our match is making on their lives. So in this, I'm about to show you some of our preliminary outcomes. The orange oval shows you the baseline numbers that we have. As you can see from this chart, our recruitment and ongoing measurement in our measurement are ongoing. So we have people who are currently in our program. We have people who have finished the curriculum but are coming back to do the follow-ups and are also continuing with their match. So we're getting close to finished, but we're not complete yet. I'm getting ready to show you some of the baseline characteristics among 373 people that we've worked with so far in Philadelphia. And then I'll show you some of the very preliminary outcomes of the impact that our curriculum has had on the members of the network, and that number is 224. So launching into some of the baseline characteristics to help people understand the levels of violence and adversity that people are experiencing, we'll show you some of our baseline outcomes. This first series of measures is about exposure to community violence and just violence overall. And these are some of the measures that we have. As you can see, 42% have seen someone else get beat up or mugged. They've heard gunfire. About half of our members have seen a seriously wounded person after an incident of violence. 31% have seen a person who is dead that's not at a wake or a funeral. And also hearing about someone being killed. This is not our comprehensive measure of exposure to violence, but it helps us to help you understand the level of violence that people are experiencing in the city of Philadelphia who are participating in TANF. That in and of itself is exposure to trauma and adversity. The next baseline characteristics are those who have experienced adverse childhood experiences. So you can see that 27% reported having no ACEs, 33% reported having 1 to 3 ACEs, 35% reported experiencing 4 or more ACEs, which is often considered to be ACEs high. And there's a lot of research over the past decade and a half on adverse childhood experiences demonstrating that it's 4 or more ACEs are related to many chronic diseases, major behavioral health problems, problems staying employed, STDs, lots of risk-taking behavior, and depression. So this is extremely important to consider. And this is, of course, why we have integrated a trauma-informed approach and behavioral health into education and training. So now we're going to show you what's been happening over time. The sample size has reduced. This is overall preliminary outcomes among our whole sample. At baseline, 60% said that their health was good or excellent, and that increased over a 12-month cycle for them to about 70%. Of course, you're probably wondering, well, if that's overall, what about those who had ACEs high? And was it statistically significant? Yes, it is. Only 46% said their health was good or excellent among people who had 4 or more ACEs. And we were able, our program, it looks like we've had success in helping people to rate their health to be better by the end of the measurement cycle of 12 months. Now on to depressive symptoms. This is our sample overall. 55% reported that they had that they were depressed. That's 10 or more affirmatives on the CESD, which is our measure. 55% reported that they were depressed at baseline. That went down to 47%. That's not statistically significant, but among those who reported high ACEs, had much higher rates of depressive symptoms at the outset, and we've been able to get it down to 54%. That's statistically significant. So you may think, okay, well, have you controlled for these changes? What has the impact of the actual intervention itself had on these particular members? And what is the relationship between their depressive symptoms and their level of participation in the curriculum and in the peer support? These are preliminary data. I'm warning you, this is not our final product, but we really wanted to demonstrate that we are measuring and that things are moving along. And this is controlled for those who have high ACEs, that it is actually quite clear that our program is having a statistically significant impact on reducing depression among those who are participating in our program. We do not see significant results among the child development among the children of the caregivers that we're seeing, and also we don't see any changes in self-efficacy. We can discuss later. We've also thought to look, again, since we're getting ready to calculate the cost savings to both TANF and Medicaid, we wanted to look at some high-cost care, high-cost issues among our participants. And so we have been looking at drug use, weekly drinking, and binge drinking, and it seems as if we're having some kind of interesting and significant impact on reducing weekly drinking and binge drinking, and this, again, is controlled for those who have high ACEs. We're going to continue to be looking at that data, and as soon as we can get the administrative data, we'll be able to calculate the cost savings as well. Just a quick synopsis on what's going on with household food security. Only among our full sample, less than half said that they were food secure at baseline. That's moved up to about 70%. Among the entire sample, what's been happening for those with high ACEs, we've had also very good results there. On employment, as expected, because most people come to us unemployed and, of course, looking for a job. That's a part of that's what TANF is about. So we can't necessarily say that this is just our program alone, but employment has increased, and we've had good success among those who have high ACEs. We also learned from the members of the Building Wealth and Health Network about how things went for them from their perspective in their classes. So we asked them to describe what they were like at the beginning of class and what they feel like at the end, and they can use words or pictures. I just wanted to highlight the one on the top left-hand side, that a person said that they started out stressed, dependent, broke, stuck, unworthy, and that at the end of the 16-week sessions, they talked about being focused, loved, self-aware, stable, and saving. Another one on the upper right-hand corner said at the end they have a sense of self-love, self-respect, that they pray more, that they are, more compassion for themselves. The one that I like to also highlight is the one on the lower right-hand side. There's a picture of a woman who said, I had a huge weight holding me down, and then at the end of the program, she said, I took that weight and built a better life for us. Okay, before I go to the next one, I just wanted to let you all know that the state has been very supportive of this program in name and being able to help us and being able to provide us with members in our program. They have not put any funds behind it until this fall, where they wanted us to expand in a career link, or this is a place where they do active education and training with many people on cash welfare. So they're asking us to scale up our program. We're piloting it this fall in the career link. We launched in October of 2017. That pilot began with 50 TANF clients, and this is preliminary data because they're constantly monitoring how many people in our program gained employment and how many people in TANF gained employment, and they compared the people in the Building Wealth and Health Network to those who are receiving regular TANF programming, and we have much higher rates among those who are in the network of helping people to gain employment. Also, they don't want people to terminate from being in the EARN program too soon because they may not have gotten the help that they need. And it looks like we've been able to keep the engagement in our program better than those who have not been in our program but who are quite similar. Promising results. So the next steps is we are going to be able to identify the cost savings for TANF and Medicaid. We're still waiting on getting administrative data from the Commonwealth, from the state. And also, now that we have really good data and a real understanding of how our program is having an impact on the members of the network, we will be starting to amp up our public dissemination effort. This is our first policy brief. It may not get up online before Friday, but we're hoping it will. This will be made available at the Robert Wood Johnson website and, of course, on our own. And this is our first policy brief out of a series of 3 where we're making the case that trauma-informed programming needs to be inserted into TANF to be more successful. So stay tuned for that. Please stay engaged with us. Stay a part of the Building Wealth and Health Network as we communicate and disseminate our findings. We're on Facebook, Instagram, and Twitter. And of course, please follow Systems for Action to stay up not only on our research, but on the other programs that are moving forward with this through this mechanism. I turn it over now to Dr. Sandy Bloom.
Hi, everybody. Can you hear me?
Yes.
Yes, we can hear you, Sandy.
Okay, good. I guess just a little further explanation of the reason why sanctuary and self are so important. The sanctuary model is a whole organizational approach, and it gets all of the staff that are involved in alignment with each other, particularly around key fundamental trauma-informed values and knowledge. And then, as Mariana highlighted, self as a tool is designed to really focus on the key domains that affect people who are exposed to relentless stress, toxic stress, and traumatic stress. And this population, as Mariana has illustrated, are the incredibly high exposure. So the 4 key domains are what gets eroded for people as a result of these experiences. So the ability to maintain safety, to manage your emotions, to deal with loss and move on into an imagined future that is possible, and really plan and see the feedback of your actions as you go. So you will hear from that description that although those are the 4 key domains, we don't focus on trauma per se. I know a lot of programs in and out of behavioral health are very hesitant to really bring up the issue of trauma because there's all kinds of fantasies about opening up Pandora's box. And we don't find that to be really the case, but self really helps you deal with the main domains without having to push people further into talking about things they're not ready to talk about. It's a simple language. It's non-pathologizing. And I think the kind of one of the primary things that it does for people is that it gives them a tool to organize the chaos that is in so many people's lives who are living in poverty, trying to deal day to day with overwhelming stressors that there doesn't seem to be any end to. So the beginning of taking charge of your life is really getting organized and making a plan and developing priorities. And that's what self really helps the people in this program to do. They will often, our experience has been, share that tool with their growing children so that the children are able to organize their own lives in a better way. And it makes life seem not quite so out of control. And that makes people feel less overwhelmed, less alone, and improves self-esteem. And I also wouldn't underestimate in the process of what the center is doing in this program, it's a group approach. So as reflected, I think, in some of the pictures of before and after that Mariana was showing, that the women feel more connected and more loved. And that's coming out of experiencing all this in a group process, getting a better handle on your finances, but also getting a better handle on your emotional dysregulation, and recognizing that other people are going through this as well. So it's not just you. You're not the one that is the only one that is deficient, that you really are a victim of terrible circumstances, and you need to become a survivor and take charge of your life and do things that will really help you be healthier in every way. And SELF helps you organize that. That's why it's such a powerful tool. So I think I only have a few minutes, so I know we want to have time for questions, but I'll be happy to answer any questions people have as we continue.
Thanks, Dr. Bloom. And now we'll just turn the mic over to Dr. Zeliak for his thoughts on the presentation.
Thanks so much for inviting me to comment on today's presentation by Mariana and Sandra. And, I want to highlight a few things. First, TANF remains a highly relevant program to the lives of low-income families in the United States. Many people are want to kind of discount it because it's shrunk in size in terms of the federal contribution to TANF. The initial block grant was $16.5 billion in 1996, and because Congress has not increased that allotment for inflation, it's down almost 40% in the 21 years since passage of the legislation creating the program. That said, states, however, have a maintenance of effort requirement and have also used additional state funds, so that total aggregate funding in inflation-adjusted terms remains around $28 to $30 billion a year, so much higher than the federal contribution to the program. And so it remains a player in the well-being of low-income Americans. And thankfully, Mariana and her team have been working very hard for many years now, doing important research in the city of Philadelphia and elsewhere on the TANF program and related. And as director of the Center for Powder Research here at Kentucky, I've had the privilege of supporting some of their prior work a few years back as part of an initiative on food insecurity amongst children in the U.S. So I'm delighted to see the team move forward in this domain on this very important work. I want to highlight the first generation research on TANF. So this is the work in the years right before passage of the law and like the first 5 or so years after passage of the legislation in '96, tended to focus primarily on two major outcomes. One is the effect of the legislation on participation in the program, and then secondly on employment in the program. There were a few, as it were, voices in the wilderness highlighting important issues about employment and barriers to employment. There was a team of researchers led by Sheldon and Sandy Danziger at University of Michigan who conducted the women's employment survey in the state of Michigan that followed a group of welfare leavers in the state. And they produced some very important early work on the importance of understanding barriers to financial success amongst the TANF population. And I view today's work as an important extension and outgrowth of that first generation research. It turns out then that's kind of what we might call the second generation of research in the TANF program kind of expanded the lens beyond just work and welfare participation to look more broadly at health outcomes. And by and large, the literature was fairly mixed. Some research found that welfare reform had negative effects on both maternal and child health. Some studies found no effect on maternal child health. So there is, it's hard to draw kind of a consensus conclusion from the impact of TANF on health outcomes. But what's notable is that the number of studies examining health and more broad measures of personal well-being pales in comparison to the number of studies that focused on the employment or welfare participation effects on TANF. And so again, sponsoring the Systems for Action team sponsoring this research, I think is really crucial in our further understanding of the impact of TANF on health and well-being amongst low-income families. What I like about the work in particular is that it's using TANF as a vehicle for improving both the health and the economic welfare of the clients, of the people there in Philadelphia. And obviously, it's the aim is to move beyond that. And I want to underscore kind of the importance of this. When the legislation was both being discussed in Congress and as states implemented it in the late 1990s, there was a strong push towards what was known as kind of the work-first emphasis. And this was based on a randomized controlled trial in the state of California called, the acronym was GAIN, which is Greater Avenues for Independence. And what came out of that was known as, in the social welfare world, as the Riverside Miracle, which is basically that Riverside, California adopted a work-first strategy. So they took their clients in the AFDC program and basically tried to immediately move them into work. And the evaluation team documented a statistically significant and economically important increase in earnings a few quarters out after this work-first strategy, compared to other counties that adopted alternative strategies known as the human capital development approach, which is really what Mariana and Sandra's team is focusing on. There was a reevaluation of that GAIN program several years later. And what they found out is that the counties that actually took more of the human capital development approach had better long-term outcomes amongst their clients than those counties like Riverside that emphasized work first. And so what it suggests is that policymakers, I think, were a little too quick to jump the gun on jump on the bandwagon and work first, because developing human capital takes time. It takes a lot of intensive treatment, but given time and treatment, we can realize substantive positive gains. And I think we're getting hints of that in the program that Mariana and Sandra were talking about today, which I think is fantastic news. I also want to underscore the importance of this is that the TANF program itself is up for reauthorization. And so bringing to bear policy-relevant research like that presented today, and how TANF can be refocused towards a more comprehensive case management as opposed to get them in and out of the door as quick as possible approach, can have real substantive positive effects within the family. And so we need to kind of get the word out that there's this important work going on, that this has to be incorporated in any type of further changes that might come down the pipe with the TANF program, it's likely there's a reasonable chance Congress will take it up in the new calendar year, in part because we've heard from the leadership in Congress that the social safety net will have to be examined closely in light of the tax cuts that were being passed today as we speak by the House and Senate, that they're going to have to come up with some additional resources to help fund this tax cut. And two programs that are potentially on the block, as it were, are the SNAP program, Supplemental Nutrition Assistance Program, or the food stamp program, as well as the Medicaid. And there have been proposals by some members in Congress, including Speaker Ryan, to block grant those programs to states, and using TANF as kind of a benchmark program in the design or potential redesign. Well, I personally think that's a bad idea to block grant SNAP or Medicaid. What we need to do is make sure that we convey rigorous research that we have on the TANF program to the policy community so that states are prepared if in the event they are discharged with new responsibilities in the organization and administration of programs like SNAP and Medicaid, and kind of underscore the importance of this human capital development approach and this comprehensive case treatment. I want to mention not only the California GAIN program, but another project that was done is actually also funded out of the same mechanism sponsored by the U.S. Department of Agriculture that Mariana received support on. And this was a randomized controlled trial in the state of Indiana, where they were using the SNAP Ed program as a vehicle to see whether or not more intensive education on healthy eating and meal planning and things like that would have a positive effect on food security of households. And the researchers did a randomized controlled trial, much like Mariana is doing there in Philadelphia, and they found very important and sizable reductions in food insecurity at the household level a year after the implementation and the participation in these kind of comprehensive nutrition education programs. Again, it's underscoring the importance that when we, as both researchers and in the policy community, are dealing with a very vulnerable population, those individuals who face substantial barriers to both individual and family success, that we have to take a very comprehensive and broad look at their current capabilities and what we can do to intervene to help them out and help them move forward. And so with that, I think I'll stop because it would be remiss of me not to make I think a couple of suggestions based on the results, as the team moves forward. And one of the things that the team's very well aware of is that because they're dealing with a very volatile and population in the sense of their lives are volatile, and that it's hard to track them down. And so one of the challenges that they clearly face is that participation in the follow-up surveys declines over time. And so I would encourage them to, as they're moving forward with their research, that they, carefully present, in their analyses, what the characteristics of the sample who are participating, say, at 12 months looks like compared to the sample in 6 months and the sample at baseline, so that, the reader has a good sense of the characteristics of the sample who are kind of the stayers as opposed to leavers. And then something else, I view as a little bit of a puzzle is that you saw an improvement in food security amongst the subpopulation of the ACEs, with the 4 more ACEs, there was an improvement initially, but then there seemed to be kind of a tapering off. And so kind of understanding, some of the internal dynamics within the household of why food security might taper off over time in that population, I think would be really important to get a better understanding of. And I think I'll stop there.
Thanks so much, Dr. Ziliak. I'd like to remind folks to please be typing your questions in the chat box. We'll be getting to those in just a moment. But first I'd like to ask Mariana and Sandy if they would have anything they'd like to respond to in Jim's comments.
Dr. Ziliak, thank you so much. This is Mariana Chilton. Thank you so much for your commentary and your insights on many studies and also ours as well. And I was really glad that you put this into its greater context of what's happening on the Hill as we speak and what's ahead for TANF and Medicaid and SNAP. So it's interesting that the language of welfare reform has somehow returned back to the Hill, and we hope that we're prepared to help inform that dialogue. Also, in terms of the follow-up, it's really great feedback about making sure that we're communicating with our listeners, and as we disseminate, that we talk about the loss to follow-up and what are the characteristics of those who are at the 12 months versus those who start out at baseline. We've been looking at that, and again, the results are quite preliminary, but it looks as if that the folks who are with us at the 12-month mark are quite similar to those who are at baseline, which is great news for us. Again, we don't want to call it just yet because we do recognize we have still more coming in that are finishing out the program. But we have been looking at that, and I will make that more obvious, and we'll have our own slide on that as we continue forward. Certainly, the tapering off on the food insecurity is something that we want to look at. We'll take some more thoughtful analysis of what's going on over time. We also have recognized that the housing insecurity or housing security tapers off. So things seem to be going well up at the 9-month mark, but then things start to go down, and so we're not really quite sure about why those numbers go down again. Is it statistically significant drop? And we are, we'll be looking within our own data set, but we will be also doing some focus groups to share our results with the members of the network so that we can get some of their insights as to what's happening between the 9 months and the 12 months. Thank you again for those insights, and I was really glad that you were able to comment.
Thanks, Dr. Chilton. We have a couple of questions in the chat box, so I'd like to start with Connie's question. She notes that her aunt is on TANF, and there just aren't another 6 hours each week, plus travel time, plus travel costs to participate in another program for which benefits are ambiguous, which leads her to wonder how you got buy-in from participants and what the attrition rate was.
Thank you so much for this really important question. I think that the buy-in is something that's really important to think about because most of the people that we talk to really dislike going to the county assistance office to apply for benefits and feel like they're not treated well, that they're not respected, that their time is not respected, and that the frontline caseworkers are often quite impatient, and people have to lose a lot of time. To get started with this program, we recruited in the county assistance office itself, and my team, recruitment team, is quite friendly. We're a smiley bunch. We also, interestingly enough, bring a cart with our own little pots of fake flowers. We bring lots of snacks, and we're just generally friendly. So when people say, when a caseworker, in terms of the recruitment, the caseworker could say, okay, there's a program here at Drexel that does some kind of a savings scheme, helps you open a bank account and helps you with your finances, or do you want to do TANF as is? And then they would sort of look over the wall or to the other side of the room and see us smiling there with snacks and flowers. They would, this is what they described to us, is that they would naturally gravitate to us because we have a humanistic approach, treated everyone with great respect, and recognized very much, made them feel welcome and that they mattered and that were important, and we thought of them as people, not as numbers, as someone to move through the program. In order to keep the, from county assistance office to an EARN center, that's what they call it in Philadelphia, or to an education and training program, the drop-off rate is 50%. We had sort of a similar drop-off rate when people, they're about a little less than 50% dropped off right at the outset. And then from there, another, I'd say, 15% dropped off after the first couple of weeks. But once people were there at the 3rd week mark, they tended to stay in our program. And what they talked about is what was really important for them was that sense of a network, a sense of friendship that they had with the other members of the program. And also they recognized they got some support from our financial and our self-empowerment coach that went beyond the curriculum itself. So, and people do enjoy coming back for the follow-up surveys. Of course, we pay them for $25 for every survey that they do, so there is a financial incentive. But they also enjoy coming back because we always provide resources if they have interest in a job or if they need a coaching moment with a financial educator. They will sit down with a financial coach. And that's how we've been able to keep our people in the program. We also have an advisory board for the network so that those who have been through the program who like to stick around and help to advise us with improving our program. We have the advisory board that meets quarterly and then has a number of subcommittees that meet on a weekly basis sometimes, and that helps to stimulate their interest in some of the things that they're interested in, such as behavioral health and banking. We have a group that wants to start their own bank. We're helping them to do that. And so we are really responsive to what their particular needs are and help to find them the resources, and that helps to keep them engaged. On our slideshow, you'll see the engagement for the research. It does, by the 12-month mark, about 50% of that original sample comes back for the research, but that's not necessarily reflective of the people who go through the curriculum program. And we can add another addendum slide or put in on that website some of the participation rates in the classes themselves.
Thank you so much. We have time for just one more quick question. And the answer may be to have a look at the briefing documents and other materials, but I'm going to tee this question out for any of our speakers. Can you recommend a website or websites, just one or two, that can provide some good indicator data about TANF success and outcomes?
Jim, you have long experience in TANF. I will cede that to you if you would like.
Yeah, that's a great question. Probably the best website to find, well, there are two locations that I would recommend. One, I would go to the Center on Budget and Policy Priorities. So it's www.cbpp.org. And just do a search on TANF. They do a lot of kind of ongoing research and reviews of TANF. The other would be to go to the Assistant Secretary for Planning and Evaluation website. That's aspe.hhs.gov, G-O-V. And they actually have reports, annual reports that they produce on TANF outcomes. And so the ASPE would probably be the place where you can get kind of the most up-to-date evidence on TANF outcomes.
Thank you so much, Dr. Ziliak. And you can see that the chairperson has added those links in the chat box. So please feel free to grab those while we close down our meeting. I'd like to thank again our excellent speakers, Dr. Mariana Chilton, Dr. Sandra Bloom, and Dr. Jim Ziliak. Want to take a moment to point out that this is our last Research in Progress webinar for 2017, but we'll be ramping things back up again on January 10th of 2018. It's hard to believe we're already at the end of the year. We'll be hearing from our collaborating research center in Indiana, and we have some additional webinars online that you can see if you visit our archives, other Research in Progress webinars from the past, and then you can also see the calendar here going forward. We hope you will join us for these. Again, thanks to our incredible speakers. Thanks to our team here at the University of Kentucky for running the technical side of this show, and we wish you all a happy holiday season. Thanks so much for joining us today. Goodbye.
The phone.